Welcome to this channel, where we provide educational content on medicine, pharmacy, and health to empower your learning and practice. Today, we're exploring pharmacogenomics as part of our pharmacology quiz series, testing your knowledge on how genetics influence drug responses. Be sure to check out the companion video on this channel, which provides an overview of the main concepts of pharmacogenomics. The link is available in the description below. Quiz instructions. This quiz consists of 10 multiple-choice questions, each with 5 options. Only one of these options is correct. For each question, I'll provide the correct answer along with a detailed explanation. Additionally, I'll explain why the other options are incorrect to help solidify your understanding. Take your time to think about each question before I reveal the answers. Let's begin. Question 1. Which of the following drugs requires routine pharmacogenomic testing before prescription due to the risk of severe hypersensitivity reactions? Option A, allopurinol. Option B, carbamazepine. Option C, phenytoin. Option D, clopidogrel. Option E, fluoxetine. The correct answer is option B, carbamazepine. The explanation is as follows. Carbamazepine requires pharmacogenomic testing for the HLA-B*1502 allele, especially in patients of Asian descent, due to the increased risk of Stevens-Johnson syndrome and toxic epidermal necrolysis. Identifying carriers of this allele can prevent life-threatening hypersensitivity reactions. Here is the explanation for the incorrect options. Option A, allopurinol does not routinely require pharmacogenomic testing, although HLA-B*5801 testing may be relevant in some populations. Option C, phenytoin, while associated with hypersensitivity reactions, does not have routine pharmacogenomic testing requirements. Option D, clopidogrel requires testing for CYP2C19 polymorphisms but not for hypersensitivity reactions. Option E, fluoxetine is not associated with hypersensitivity requiring genetic testing. Question 2. A patient with a CYP2C19*2/*2 genotype is likely to exhibit what kind of response to clopidogrel therapy? Option A, enhanced therapeutic response. Option B, normal therapeutic response. Option C, reduced therapeutic response. Option D, severe adverse effects. Option E, no metabolism of the drug. The correct answer is option C, reduced therapeutic response. The explanation is as follows. The CYP2C19*2/*2 genotype indicates a loss-of-function mutation that impairs the metabolism of clopidogrel to its active form. This results in reduced platelet inhibition and an increased risk of thrombotic events. Here is the explanation for the incorrect options. Option A, enhanced therapeutic response is not possible with a loss-of-function genotype. Option B, a normal response occurs only in patients with functional CYP2C19 alleles. Option D, severe adverse effects are not directly associated with reduced clopidogrel activation. Option E, metabolism is impaired but not entirely absent with the STAR2/STAR2 genotype. Question 3. Which enzyme's genetic variation is primarily responsible for altered warfarin dosing in patients? Option A, CYP3A4. Option B, NAT2. Option C, CORC1. Option D, UGT1A1. Option E, G6PD. The correct answer is option C, CORC1. The explanation is as follows. Genetic variations in CORC1 affect the sensitivity of the vitamin K epoxide reductase enzyme to warfarin, influencing the dose required for anticoagulation. This makes it a critical determinant in personalized warfarin dosing. Here is the explanation for the incorrect options. Option A, CYP3A4 is not significantly involved in warfarin metabolism. Option B, NAT2 is unrelated to warfarin's pharmacodynamics or pharmacokinetics. Option D, UGT1A1 is associated with bilirubin metabolism, not warfarin. Option E, G6PD affects oxidative stress, not anticoagulation. Question 4. Which gene is a key determinant in thiopurine metabolism and is associated with myelosuppression in patients treated with azathioprine? Option A, CYP2C19. Option B, TPMT. Option C, CYP3A5. Option D, SLCO1B1. Option E, ABCB1. The correct answer is option B, TPMT. The explanation is as follows. TPMT, thiopurine methyltransferase, polymorphisms can result in reduced enzymatic activity, leading to the accumulation of toxic thiopurine metabolites and an increased risk of severe myelosuppression. Testing for TPMT activity helps guide safe azathioprine dosing. Here is the explanation for the incorrect options. Option A, CYP2C19 is not involved in thiopurine metabolism. Option C, CYP3A5 metabolizes other drugs, not thiopurines. Option D, SLCO1B1 is related to statin metabolism, not thiopurines. Option E, ABCB1 impacts drug transport, not thiopurine metabolism. Question 5. Which statement accurately reflects the influence of CYP2C9 polymorphisms on warfarin metabolism? Option A, polymorphisms result in increased drug clearance. Option B, polymorphisms lead to a decreased risk of bleeding. Option C, polymorphisms have no significant effect on drug levels. Option D, polymorphisms cause decreased drug clearance and increased sensitivity. Option E, polymorphisms primarily affect phase 2 metabolism of the drug. The correct answer is option D, polymorphisms cause decreased drug clearance and increased sensitivity. The explanation is as follows. CYP2C9 polymorphisms reduce the enzyme's activity, leading to slower metabolism of warfarin. This results in higher plasma levels of the drug, increasing its anticoagulant effect and raising the risk of bleeding complications. Patients with these polymorphisms often require lower doses to achieve therapeutic effects safely. Here is the explanation for incorrect options. Option A is incorrect because CYP2C9 polymorphisms do not increase drug clearance, instead, they slow it down. Option B is incorrect because these polymorphisms increase the risk of bleeding, not decrease it, due to heightened drug levels. Option C is incorrect because CYP2C9 polymorphisms significantly impact warfarin levels, altering its pharmacokinetics and clinical effects. Option E is incorrect because CYP2C9 polymorphisms affect phase 1 metabolism, not phase 2 processes. Question 6. Glutathione-transferase, GST, polymorphisms are most likely to affect the metabolism of which drug? Option A, paracetamol. Option B, cisplatin. Option C, codeine. Option D, warfarin. Option E, ibuprofen. The correct answer is option B, cisplatin. The explanation is as follows. Glutathione-transferase, GST, polymorphisms can significantly affect the detoxification of drugs like cisplatin. GST enzymes catalyze the conjugation of glutathione to reactive electrophiles, and variations in these enzymes can influence the efficacy and toxicity of cisplatin. Here is the explanation for incorrect options. Option A is incorrect because paracetamol metabolism is primarily dependent on glucuronidation and sulfation pathways, not GST. Option C is incorrect because codeine metabolism is influenced by CYP2D6 polymorphisms, not GST. Option D is incorrect because warfarin metabolism is affected by CYP2C9 and CORC1 polymorphisms, not GST. Option E is incorrect because ibuprofen metabolism is primarily via CYP2C9 and phase 2 conjugation processes, not GST. Question 7. Which statement is correct regarding polymorphisms in UGT1A1? Option A. Polymorphisms lead to increased risk of Stevens-Johnson syndrome. Option B. Polymorphisms cause reduced irinotecan metabolism and increased toxicity. Option C. polymorphisms enhance the efficacy of clopidogrel. Option D, polymorphisms decrease the acetylation of drugs like hydralazine.
Option E, polymorphisms result in rapid metabolism of codeine.
The correct answer is option B, polymorphisms cause reduced irinotecan metabolism and increased toxicity. The explanation is as follows. UGT1A1 polymorphisms reduce the glucuronidation of SN38, the active metabolite of irinotecan. This leads to an accumulation of SN38, causing increased toxicity, particularly diarrhea and neutropenia.
Here is the explanation for incorrect options.
Option A is incorrect because Stevens-Johnson syndrome is typically associated with HLA-B polymorphisms, not UGT1A1. Option C is incorrect because clopidogrel efficacy is influenced by CYP2C19 polymorphisms, not UGT1A1. Option D is incorrect because acetylation is mediated by NAT2, not UGT1A1. Option E is incorrect because codeine metabolism is affected by CYP2D6, not UGT1A1.
Question 8. Which of the following is a primary role of the organic anion-transporting polypeptides, OATPs, in pharmacogenomics?
Option A, mediating drug excretion in the kidneys. Option B, facilitating the efflux of drugs from cells.
Option C, transporting drugs into hepatocytes.
Option D, conjugating drugs for metabolism. Option E, reducing the efficacy of drugs through rapid metabolism. The correct answer is option C, transporting drugs into hepatocytes. The explanation is as follows. Organic anion-transporting polypeptides, OATPs, facilitate the uptake of a wide range of drugs, including statins, into hepatocytes. This is crucial for hepatic metabolism and excretion, and polymorphisms in OATP genes can impact drug pharmacokinetics and response.
Here is the explanation for incorrect options.
Option A is incorrect because drug excretion in the kidneys is primarily mediated by transporters like OCTs and OATs, not OATPs.
Option B is incorrect because drug efflux is handled by ABC transporters like P-glycoprotein, not OATPs.
Option D is incorrect because conjugation for drug metabolism is performed by enzymes like UGTs and not transport proteins like OATPs.
Option E is incorrect because OATPs do not reduce drug efficacy, instead, they are involved in drug uptake. Question 9. The polymorphism of the SLC01B1 gene primarily affects which of the following drugs? A. Metformin. B. Atorvastatin. C. Warfarin. D. Omeprazole. E. Amoxicillin.
The correct answer is option B, atorvastatin. The explanation is as follows. SLC01B1 encodes OATP1B1, which is responsible for hepatic uptake of statins like atorvastatin.
Polymorphisms in this gene can reduce statin uptake, leading to increased plasma levels and a higher risk of statin-associated muscle toxicity. Here is the explanation for incorrect options.
Option A is incorrect because metformin transport is mediated by OCT1, not OATP1B1.
Option C is incorrect because warfarin metabolism is influenced by CYP2C9 and CORC1 polymorphisms, not SLC01B1.
Option D is incorrect because omeprazole metabolism is primarily affected by CYP2C19 polymorphisms.
Option E is incorrect because amoxicillin is not significantly impacted by OATP1B1 polymorphisms.
Question 10. A 42-year-old man is being treated for HIV-induced acquired immunodeficiency syndrome, AIDS. When abacavir therapy is begun, he develops a severe skin rash.
Which of the following pharmacogenomic diagnoses might explain this skin rash? Option A, CYP2D63, poor metabolizer. Option B, CYP3A53, poor metabolizer. Option C, HLA-B57:01, extensive metabolizer. Option D, SLC01B15, poor metabolizer. Option E, UGT1A1*28, poor metabolizer. The correct answer is option C, HLA-B*57:01, extensive metabolizer. The explanation is as follows: HLA-B*57:01 is strongly associated with hypersensitivity reactions to abacavir. Patients with this allele are at a significantly higher risk of developing severe immune-mediated adverse effects, such as skin rash. Here is the explanation for incorrect options. Option A is incorrect because CYP2D6*3 polymorphisms affect drug metabolism, not hypersensitivity reactions. Option B is incorrect because CYP3A5*3 polymorphisms are associated with altered drug metabolism, not abacavir hypersensitivity. Option D is incorrect because SLC01B1*5 affects statin transport, not abacavir reactions. Option E is incorrect because UGT1A1*28 polymorphisms impact glucuronidation, not hypersensitivity to abacavir. Tips for revision. As a form of recap, take note of the following 4 tips to help you tackle similar questions effectively. The first tip is that always identify tricky words like not or except in the question, as they can change the meaning entirely. The second tip is that understanding pharmacogenomic concepts can help you connect drug metabolism to clinical outcomes, ensuring more accurate answers. The third tip is that focus on enzyme-specific pathways, such as CYP450 variations, as they are commonly tested. The fourth tip is that pay attention to clinical relevance, such as the population groups affected by specific pharmacogenomic risks. Conclusion. That wraps up our revision on drug metabolism. I hope you found this session informative and helpful. For further reading, consider textbooks like Katsung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, or the British National Formulary, BNF, for detailed pharmacological information. These resources will deepen your understanding and help you excel in exams. Thank you for watching this video. If you have any questions or need clarifications, feel free to leave them in the comments below. Don't forget to like, share, and subscribe to this channel for more educational content. Follow us on Instagram, Facebook, and Spotify for additional resources and interaction. See you in the next video.